It's time for our first panel discussion of the day titled The Future of Data-Driven Insights for Clinical Decision Making. I'd like to ask our moderator and panelists to come out, take their seats. Our moderator today is going to be Sarah Matrice. Sarah is the clinical informationalist at Contexture and oversees the health data quality team. Dr. Edmund Baker is the current medical director for the Equality Care Center, and Tina Birnbein is the vice president of care innovation for HealthLink Advisors and president-elect of the HIMSS AZ chapter.
We're going to jump right into it. I'm really excited for us to have some clinical conversations today. As Lisa touched on early this morning, you really can't talk about the future until you kind of talk about where you are. And so in the spirit of being progress-focused, I want to see if the two of you can provide sort of an overview of our current challenges with the use of data to support clinical decision-making.
Hello, everyone. So I'll better start by telling everyone what Equality Health is. We're a value-based company that engages independent primary care practices and enables them using Medicaid first approach to close their care gaps. So in order to do this, we're trying to move them from a fee-for-service over to a value care-based model. We need data. That data we get is through the HIE and other data sources. But the issue is, all data is not good data, and there's a ton of data out there, and how do we give this to physicians who already don't have much time on their hands? I walk in a room, I have to see a patient in 15 minutes, but that's not 15 minutes in the room. It's only 7 minutes with a patient, the rest of the time trying to make sense of the collection of data that we've gotten, and 50 pages from an ER doesn't help. So using our own platform, Care and Power, we sort of put it in bite-sized bits for me so that I can walk in a room, make clinical decisions quickly, and manage patients.
Let me ask you a question about that. When you have to bite it off in bite-sized pieces, what are you afraid you're missing?
Great question. There's always a fear that I miss when you get those bite-sized data, but what I talk to our providers about is when you get that 50 pages, you're missing everything. You don't have time to go through it. You don't have not just the time, but even the cognitive ability to pull out the things you need in such a quick amount of time and make a great clinical decision. So I trust my actuarials, I trust the data from Contexture and our other sources, and our ability to put it together in a way that's meaningful clinically for me.
Tina, what about you?
Yeah, thanks so much. So I am here today wearing my Arizona HIMSS hat. I'm proud to say I am serving in the Arizona HIMSS president-elect role. And when I think about this conversation around clinical decision support and having the right information in the right amount of time for all of our providers and clinicians to work with, I can't help but think about our friends, maybe those at Mayo, for example, who aren't necessarily participating in the HIE yet, and the missing information that's so valuable that we all need for better care coordination. So strategically, I think a lot about what we can do to make sure that we have everyone across the state participating in this. And I also think about the impact of how our care and the way that we deliver that is changing, and how even more important it is to make sure that we have all of the different treatments that are being provided to an individual available for visibility to the right clinician and provider at any given time. So I could talk for days about this. Happy to be here.
Well, let's take a pivot and sort of still staying in the spirit of where we are. I want to hear from you both around sort of setting the foundation and what sort of data-enabling organizational initiatives you have within your organization.
Great question. So I mentioned Care and Power. So that is our platform. And what that does, when I say bite-sized bits, it gives us specifically which care gaps to close. For instance, there's annual wellness visits, there's annual child care visits, there's vaccinations, there's different things that have to get done to close care gaps. And yeah, care gaps to a lot of people is just a checkbox, but what it really is our ability to care for a population, a lot of which are underserved, and be able to make sure that all the things that we know that we can use to mitigate their risk are being done. So the ability to use the platform and to use data to gather information and make very good proactive choices really enables us to make very good clinical decisions.
Tina, I'd actually like to ask you a question, sort of follow up to
Please.
that. Yeah. How important for this data gathering is the literacy of our users, right? So we talk about technical and cultural adoption. We can set the mission, vision, goals of an organization, but our end users who are actually tasked with gathering this data for us, how important is that they have that literacy?
Yes, gosh, I wish we had 4 hours for this. So it's funny, we were just actually talking prior to walking up here about things that are still unfortunately complicated, like figuring out the definition of what a length of stay means to any given person. Because if you ask somebody who's on the clinical side, that answer is going to be very, very different than somebody in the finance team, for good reason. So how do we figure out as a team within an organization what it is that we're trying to do with that metric and make sure that we're pulling the right information from the right source and that we have it in the hands of the teams that are going to be able to make a difference on behalf of the patient. And that is very complicated because it brings up this, I always jokingly call it the 4-letter word called governance, right? You want to end a Zoom meeting, you want to end a team meeting, you bring up data governance because nobody wants to deal with it. You get the eye rolls, right? No one has love for that. But it's an unfortunate underpinning for how we have to work better together. So it's a really key, important part, I think, of how we're functioning. And not only are we living through this day of like incredible change right now, so the way we're delivering care is changing. We're starting to see more care driven into the home. We've embraced digital and virtual care methods in parallel. And we have new technology that are enabling us to care for patients differently as well, meaning like wearable devices and all of these things that are giving us even more information, adding to the data tsunami my friend here was referring to earlier. And so this concept of data literacy, it's so critical that we're putting in the effort and the investment as a team to really get around the table and have transparent conversations about what we're trying to do and what we need to make the changes in our workflows meaningful and better, not only for our care teams, but for the patients as well.
And I do want to start moving towards the future, especially when you start talking about all the various methods for gathering data. We want to start diving into that. But one follow-up question for you is Dr. Baker, sorry. Will this change with our as the generations retire and the younger generation who has grown in through their residency as utilizing this technology, will our challenges change?
They will absolutely change. I was an older guy going through medical school, so
I don't believe it.
I was literally 35 when I started. So I came in from another generation from the people that I was in school with. And the people I was in school with, I realized, were the microwave generation. Mm-hmm. Everything has to be done now, instantly. So how they bring their data and combine it and make clinical decisions is far different than my generation. You know, I remember learning as a young surgical intern how to diagnose disease, and none of it was instruments. None of it was an X-ray. It was all
the clinical pathway came from here, right?
It was all hands-on. It was all history. And now, we can't do anything without doing 100 tests, which adds more to the data tsunami, right? So it's going to be different. If we don't get out in front of it, it's just going to be insurmountable amount of big data and the inability to discern it all in a meaningful way.
And 7 minutes to digest it all, right? Okay, so moving forward, so the future, obviously we've touched on, is heavily data-driven and needs to be embraced for the greatest positive impact to patient care. I want to spend some time talking about what tools you're using to support this advancement. I know Melissa showed some things that Contexture has developed in partnership in her last presentation, but what are you seeing in practice?
So in practice, I mentioned before we use Care and Power, and why I use it is not just to identify things that have to get done to be proactive in that regards, but it also helps rank our risk. Identify patients that are at risk for ending up in the hospital and being those 5% of costs for our healthcare system. So what I rely on is our risk model, identifying those patients, and then I gather a team to go out, either ourselves through our complex care team, which I'll talk about in a few minutes, or giving this information to providers that they can proactively keep our patients out of the hospital. So it's the model of being proactive is key here.
And is that model always built into their workflow? Or sometimes is it in parallel too?
Well, that's the work in progress. It is meant to be part of a workflow. It's meant to be prior to a doc walking in the room, having a list in his hand, which is, again, only a one-pager, easily to read through, and the walks it takes for me to get to my desk to the room to be able to look and see what needs to be done. That's key. Giving me what I need to know in that amount of time is key. And then my ability to go in and act on it.
Yeah, thank you for that. Tina, can you touch on, just from an analytics perspective, we talk a lot about challenges with data, but there's also a lot of really great things in terms of dashboard development, predictive analytics, those types of things.
Yes, happy to comment on that. I think first the thing that jumped into my mind as I was listening is that it's not just about the data. We also have to think about how our care teams are functioning, right? So if we're in an organization and our teams aren't enabled through technology to be able to collaborate on care plans and look across the enterprise, regardless of a site of care that's being provided to a patient at any given time, they're at a disadvantage automatically. And so are any of the providers that are trying to engage and support that patient as well. So I always love taking a step back to think about, all right, what are all of the programs and the care teams that are really pertinent to an organization? Let's bring them together. Does not imply it has to be under one leadership structure, but they need to be enabled and empowered to collaborate and to be able to have that enterprise-wide care planning culture embedded with how they work for warm handoffs. And then the technology has to be there to allow them to share information together, to be able to communicate effectively together, and to make sure that regardless of where a patient shows up, they have what's needed to provide what's best for that patient. So that gets a lot about what you were saying in terms of understanding what data nuggets do I need in this moment, but knowing you've got the safety net of the care team around you and that they're keeping a close eye on that patient throughout all of their steps across their sites of care. That gets complicated and, of course, can be supported with some really strong analytics, but it all comes back to, do we have the right data to begin with? When we think about all of the different areas that a person can receive care, if we don't have that information and we don't understand what elements of that need to be escalated through any kind of predictive modeling, it makes it really hard for a physician who is trying to spend 6 minutes per patient to understand what they need to worry about before they get in front of them. It also gets more complicated if we don't have the complete story about that patient available. We have so much effort, which is definitely needed from an SDOH perspective, and a whole lot more information that we're learning about patients as we go into their home to provide care, but those things are fragmented, and they're not always available through the EHR or whatever technology platform that we're using at any given time. And so there's so much opportunity for us to continue leaning into and making sure that we're bridging the gap and we're plucking out this information to build the story that's meaningful, and we can bubble to the top the things that are really pertinent for our physicians who are running, a million miles a day, as are the care teams, to provide the best support to the patients before things escalate and they end up back in the ED. Because you mentioned, dashboards and different things that exist, I think I've definitely noticed that we're moving beyond the predictive modeling. So when I think about sepsis alerts or all of these different things that are standard now in a lot of our EHRs, I see us leaning into the next level of maturity in terms of analytics and really starting to work and understand how we can better use some AI technology to allow us to focus more on caring for the patient and not having to worry so much about who is predicted to have a condition exacerbate or who might need some better support that could be handled in this particular site of care instead of an inpatient setting. So it's those things that I'm really excited about. And I know there's a conversation later today on AI, so I'm sure some of that will be covered there as well. But I can't help but think they go hand in hand when we think about data and analytics and all of these things that we're talking about here also.
Just to jump on what she was saying.
Please.
Yes, it's so important to have all of the clinical picture.
Yeah.
The right hospitals, every hospital in this town should feed into HIE. Every part of ambulance companies, everything should feed into it. But also, not only should every entity feed into it, all the EHRs should really get their minds together and have their heads around structured data fields that can be used and pulled and make meaningful use out of the information. Unstructured fields requires me now to have somebody pull the data out and make sense out of it. The work towards having more communicative EHRs across platforms would really make a big difference.
You're speaking my language. Let's go into some specifics, I think, here. I want to understand how you're enhancing your internal data with data from external resources. So we've talked about silos. Those are all your puzzle pieces. How are you putting the puzzle together for the treatment of chronic conditions specifically?
Great question. This is where I live, and this is what I love most. So I'm going to give you the scenario. So I got a call last week, Doc, I need you to see a patient. Well, how was this patient identified? It was identified through HIE, and then our actuarials got hold of it. They risk stratified the person, realized they're high risk, falls out high risk, hospitalized patient. Equality has a complex care team, which now becomes engaged, right? The most important part of a care team are CHWs, right?
And who's on that team? What does it consist of?
So that's the physician, there's nurse practitioners, there are care coordinators, there's community health workers. And of course, the most important part of that are the community health workers. They engage a patient while they're still in the hospital. They identify the needs and schedule this person with a follow-up within the 7 days. So now, yes, we get to check a box off saying we're seeing them within 7 days, but how hard was this before when using claims data? You wouldn't get the claims data for 30 days and you had to see them within 7. It's impossible.
They could be rehospitalized.
Right, they're already back in the hospital again. So now I'm seeing a patient within 7 days. Now I'm able to go in with the CHW on the first visit and really assess this patient, take a really good picture, a lay of the land in person where they are. It's either going to be in home or a step-down unit. And as I'm looking around, I could really make decisions, clinical decisions, based on what I'm seeing. Not just what I'm hearing from the patient, but interactions between people in the house and the inability of having organized medications. And then I see the problem firsthand. So I saw Mr. B last week. And Mr. B is a guy who was diagnosed with liver cancer and keeps bouncing back into the hospital because of pain and issues dealing with that. And so when I saw him, I asked him, I said, well, why the ER? Where else? Why don't you have another outlet to, to your problems? He says, well, I have no one else. I'm alone. I live alone. I'm about to be homeless. So when I leave this SNF, I will be homeless. And I don't know how I'm going to get chemo. I don't understand, how I'm going to manage some of my medications, which need to be refrigerated. I just don't understand how I'm going to manage that. Well, using all of our data and our team, we're able now to take this data and make it meaningful. We're able to now work with community-based organizations, some which feed into HIE, to use their information to find him a place to reside that will enable him to store medication and be able to help him with transportation. So data is everything, or it could be nothing.
Right. Tina, do you want to add on to that, or I have a follow-up question for you?
What came to my mind is, for those of you that are part of a provider organization here today, quick show of hands, how many of you have thought about the concept where you would have crossover support between a CHW role and a case manager role? That's not a normal operating procedure, right? But when we think about taking care of patients differently, those are the kinds of things from the story that I love hearing, because it's the only way to build the bridge and make sure that we've got that strong network of support for the patient, and that our care teams are set up with the right information and can help that physician that's supporting that patient do the right thing for them as well. I didn't see any hands go up, so yeah, it is unusual to think about, but those are the things that are meaningful. It's connecting the workflow to the right information when we think about clinical decision support.
It works.
Yeah.
Do you want to talk about how this data is being taken advantage of as quickly as possible and just the timeliness? You touched on that briefly with the challenges, but can you also talk about the good, Tina, and having that access to the data at your fingertips?
I'm a data nerd on the inside, so this is the topic that's near and dear to my heart. And I always feel like when you look around, we have a ton of investment being spent right now inside every health system on figuring out analytics. And that actually has to move beyond what I would consider to be the operational reporting that is just standard inside every EHR, and to be able to take advantage of the information that we now have, so that we can build better predictive models and start leveraging AI in a new and different way to drive data and make it more meaningful for everyone. I still think that we spend a lot of time figuring out what we need and how we're going to get it, instead of thinking about allowing that to happen on our behalves, so that the patients that need our attention, it's directly in front of us and we can spend our time supporting those individuals. I feel like the split, when I think about a lot of our clinicians right now, is unfortunately like 50-50. A lot of data work in there that's driven into our daily workflows, and it's burdensome. And we know this, and we've got all these analytics teams trying to build out new reports, but the way that we're servicing that information has to change. You shouldn't have to log into something to go grab an operational report. It should be delivered automatically without thinking about it, right? And that's what we're on the preface of finally being able to do, because we finally have enough systems online in the cloud, so to speak, and we finally have the platforms to be able to combine that information and do something more meaningful with it, to pick that story for the patient and do what's right regardless of their site of care.
Automation and workflow integration, right?
Very true.
Yeah. Want to move on here to another more specific topic. So care coordination, great example we just heard, mainly emphasizes managing problems lists, med reconciliation, coordinating and scheduling appointments, transitioning patients between care levels, following up on gaps in care, et cetera. Ooh, almost lost my notes. We would have been in real trouble. Okay. You want to talk about in more detail around the near and dear social determinants of health data to your heart, and what that means for our patients, what you're seeing with your patients, and really what I guess more considered non-clinical data, how important it is.
Well, you can't start the conversation of social determinants of health without talking about COVID. Because COVID was the one thing that really shone a light on disparity of care. And then when you think about disparity of care, you say, well, why is that? Well, I always use clinical scenario to try to show why this is so important. And if I had two patients, say they were identical twins, separated at birth, one had a great life, the other did not necessarily have a great life, and they're both seeing me, right? And they both have diabetes. I see the first one at 1 o'clock like he was supposed to be there, and his blood pressure is fine, his sugars are well regulated on medication, easy visit, he's out the door, I'll see you again in 3 months. His unknown twin comes in, hour and a half late, right? Most practices would have kicked him out, but of course in our practice we always say, you're seen if you're here, I'm not going to send you away. So he gets seen, and his blood pressure is out of control, his diabetes is out of control, and you're trying to figure out why is it that the guy who's very similar to the other guy I just saw is so out of control and he's given the same medications. Well, when you dig down, you realize, A, he's late because he didn't have transportation, and he had to catch 2 buses. The one bus was late, so therefore he's late. The other part is the pharmacy that I sent the meds to were the wrong pharmacy, and he couldn't get to it. So he's difficulty getting his medications, and then the medications I wrote for him are too expensive. So now we're crossed over to at least 3 of the aspects of SDOH that aren't being addressed or haven't been addressed for this patient. And then understanding disease, being able to walk through literacy differences to explain a disease and the importance of taking it. And on top of it all, this is the cherry on top, and this is the reason why CHWs or community health workers are the most important part of medicine, is the trust issue. You know, people don't tend to trust us because we've given them many opportunities to distrust us. The people they will trust are people that come to their homes, people that they meet through their places of worship, their community centers, you know, things like that, where they learn to trust the people by the people they associate with. So these teams can help me mitigate all the problems that are happening for lack of SDOH met needs, and then finding solutions for them.
Yeah, thank you for that. And Tina, can you touch on, just weave in the data piece there, right? So Lisa touched this morning on what Gravity Project has done in the social determinants of health space in the last few years. We talked about in our challenges here at the beginning of unstructured data, the puzzle pieces and pulling them into workflows. Like, what can we expect from this in the social determinants of health space, knowing all of this?
Yes, gosh, that story reminded me so much of a program that I'm working on now. It's a project, truly, where we actually have a team of, they call themselves the Peer Help Team. Their focus is, as certified social workers, to support individuals who are currently incarcerated, who are in need of substance abuse support, who may struggle with some kind of mental health issue, and who are on the precipice of essentially being released and have no support in our world. And they don't know where they're going to receive housing, if they're going to be able to get into something like maybe a halfway house if that's an option for them, what kind of conditions are going to exist for any kind of carry-on probation needs, et cetera. And if you're sitting there thinking to yourselves, wow, that doesn't sound like it's necessarily healthcare related, this program is actually being created and developed and supported by a health system to these individuals, because it happens to be in an area where there is extreme socioeconomic challenges, a lot of substance abuse, rural location, and they see the value in being able to support these individuals through their entire recovery process and into successfully contributing back into society. And so when we have certified social workers who are engaging with these individuals, we have the commitment from them in order to continue participating in the program. There's all kinds of things that are being provided to these individuals, including that social worker showing up to meet them as they leave the facility that they're in, and providing immediate street clothes, providing them with a place to go for housing, helping them find employment, making sure that they have the necessary support for any kind of ongoing outpatient treatment they need, whether it's substance abuse, mental health, whatever it might be. And that's this full package type of offering, we call it, because there's so much value in continuing to build the trust with that individual and making sure that we're connecting the dots in the care plan for that patient once they are seen across that health system, regardless of the site of care. What's interesting is when I think about the data and the opportunities that we have, how many here are familiar with this CFR 42 designation? Has anyone worked with that recently? Yeah, I love the show of hands. We are challenging that designation these days when you hear me describe that program, because at first, legal and compliance teams all sat around the table and said, oh, that designation has to be there. And we asked the question, why? Because that information for that patient is super beneficial if we're using it in the right way and without being biased to support them in their care journeys. So do we really need it? And it broke the glass, and it allowed the teams to think differently and come together for enterprise-wide care planning, enabling that if there are treatment plans that are identified clearly for that individual, that those data elements are being made available to any other care team member in that organization appropriately. For any information that is maybe court-related, that is being maintained securely. And you can do that without that designation in place, but we have to think differently about the technology that we're using, how we're configuring it, and enabling our care teams to work differently together as well to serve those patients. So I think that's a really great example when we think about, the opportunities that exist, both from not only thinking differently about how we're working together as care team members, but also enabling ourselves to do things differently within the technology and making sure that we're providing and sharing data appropriately to serve those patients in the best way possible.
Thank you so much for that thoughtful response. Want to do a little time check here. I have one last question for you, and then I'm hoping there's lots of good questions from the audience that we can engage with. Imagine us here again in 5 years. We'll still look the exact same age, though. What are we going to be talking about in 5 years, right? From a clinical decision-making perspective, what's going to be important in your mind if you had your crystal ball? Will we still be talking about the same things? Hopefully not, but.
So I imagine 5 years from now, DNA data and genomic data that helps us make clinical decisions will be readily available. And that's going to, if you think you have big data now, just imagine everyone having their entire genome as part of a data field and how we're going to manage that. We need to get it right now. We have to be able to understand and how to manage the small amount of data we have now, because 5 years from now, when that's available, we're truly going to be on the precipice of being able to make decisions early on, being able to really be proactive, identify people's medical journeys years before it happens, and be able to act on it. And so Again, that doesn't remove the social aspect from it, which is completely outside of that, and we still need to be cognizant of their social needs. But medically and clinically, we just have to be better at capturing data and being able to apply it.
Not that far away. What about you, Tina?
Yeah, gosh. I think that the way we interact with data is going to completely change. And what I mean by that is, you know, you heard me mention earlier, I think a lot of our teams really struggle with creating time to have discussions around things like, oh, we're reducing readmissions. What metrics are we using for that? What's our length of stay? What do we mean by that, right? A lot of manual data digging. We've all got our data dealers, right? And I think the way that we're working today is going to completely shift with the integration of AI, and a lot of that is going to become more automated as we start turning ourselves into, you know, that term prompt engineer. Is anyone familiar with that here today? I hope we're covering it, just a couple hands, which I love. Hopefully that's being covered this afternoon too. I'm excited about it. But that's really where, you know, we'll be able to interact verbally and ask a platform, hey, I need, you know, this data set, and it delivers it immediately, right? So we don't have to worry so much about our data mining skills or the interpretation of it as much. It's delivered to us in a really easy format. So the way that we work with it today is going to drastically change. I think the other thing that I see starting to happen that really makes me hopeful is just this acknowledgement of how many other things are factors in all of our care. And I am really excited about the journey that I see our industry on around women's health, normalizing perimenopause and menopause healthcare models, and really bringing that into the mainstream so that it becomes a part of our care journey. There are things that are unique between our genders that I think we haven't quite figured out on how we're going to manage appropriately as part of our overall care plan, and making sure that we have the right support for patients at the right time based on where they are in their journey in life. And so I see a whole lot of that finally starting to come to fruition when I think about the work we're doing in the SDOH space, especially around these factors that we talked about, you know, understanding somebody's living condition. What is that like? What do they need? Where should they go for care that's the most appropriate for them at any given time and stage based on the factors they are managing? So I think all of that we'll be dealing with very differently in 5 years. And I think our conversations are finally going to get to a place where, I love you mentioned, you know, genomics and the things that we have to anticipate will become the things we worry about from a wellness perspective. That's a really great place to be finally.
Thank you both. Hopefully we have a few more minutes for questions.
So get ready.
Oh, goodness.
I love that.
All right, so this is the highest voted question of the entire day so far, and this is for all three of you. In our experience, we have found that most providers cannot read or understand data. How do you identify who to give data to in terms of a provider's office?
Well, I'll jump on it first. Well, that's an interpretive problem. Someone needs to be able to interpret that information and give it to the people in the office in a way that we all can digest it. You know, and so that's a problem that we have to work on when it comes to data. A person walks in my office and they speak another language, I get somebody to interpret for me. So where that interpretive service lies, I think it lies on the side of the people that deliver the information. They need to deliver it in a way that I can understand it.
Yeah, gosh, I agree wholeheartedly with everything you just mentioned. I think there's this layer too where we have such a big investment in analytics teams, but we don't invest so much in what I call the data visualization delivery of it, meaning that pulling the information is one thing, but putting it into a format that's easily interpretable is requires a different skill set than what an analyst or a data scientist might have. And if we're not accounting for that in our analytics teams, it can make it really cumbersome for our care teams to have to then take that information and figure out how to work with it. So I always stress, if I'm working with an analytics team, be thinking about that, because the way you're delivering the information to your providers, to your nurses, to your care team members makes a very big difference in the way that they work and how much they're able to get done on behalf of the patient.
These next two questions are very, very similar, but they address different things, so I'll kind of combine them. How do you assess the data literacy of the staff or organization, and is there an industry standard, as well as, where is it? So everyone's upvoting right now, so it's changing. One second. Yes. And then on top of it, how do you engage front staff in data clinical decision making?
So there is no industry standard. There probably won't be one, I don't think, for education, not anytime soon. That being said, just remember, when you put data out to members, patients, whatever they are to you, when you put information out, it has to be at the 7th grade reading level, right? So it's our job to make sure that what we're trying to communicate to you is easily understood. I say it's the same for the delivery of data. So the job is to give it to me in a way that we can understand, whether it be me, the physician, or the office staff, or whoever receives that information. And it has to be reasonable. I mean, I think that to say that it could be high school graduate level or maybe 1-2 years at college level, that should be enough for anybody to understand when it comes in through the front door.
Yeah. I'll just add that I feel like data literacy is cultural. And if we're not investing as an organization in understanding how to drive that culture, we have to start there. It's not about, the 10 tool sets, it's the conversations with our staff around the tables about what information don't you have that you need? How are we going to work quickly to provide that to you? That to me is just, it's got to be built into the way an organization functions, and that's the only way to help a team realize that data is an asset. We oftentimes don't work to treat it that way.
So all of you folks can answer this one, but this one is to you, Dr. Baker. You have experience with both worlds, making clinical decisions with limited diagnoses, and now with tons of data available at your fingertips. Based on your experience, do you see a substantial difference in your patient's actual health outcome due to those additional diagnoses and data available?
Because I come from both worlds, I could say that the implementation of data into my decision-making has helped me tremendously. But I'm afraid that some of the younger docs or providers that are learning only from the aspect of data are losing some of that old skill of being able to diagnose somebody. If the lights go out right now, I should be able to diagnose a heart attack.
Which happens.
Right.
Right?
It's going to happen.
Downtimes happen.
It will happen. So we need to maintain both sides of that. And of course, we're going to have to put the emphasis on data now because it is available, how that can augment us, but it shouldn't be everything we do.
Yeah, it's funny, we were talking about this before we were up here on the panel. It is a real worry these days in how we're training our new residents, our new nurses, our new care team members, because we're becoming so reliant on any kind of automated information. God forbid if the cloud goes down or we can't access the EHR, how are we going to function for days? And that may not sound like, a long period of time, but when you're trying to treat, maybe if it's 18 patients a day, that has a substantial impact if we miss something. So we were just referencing, this balancing of having some kind of mentorship or ongoing education to make sure that those that are coming out of graduation early are learning from those who've been inside an organization and part of a care team for 10 years plus, so they can understand the balancing act of, yes, we absolutely have to take advantage of the information that's at our fingertips, but we also have to make sure that we continue to learn and grow around the clinical expertise that we carry within us to always be able to function without those IT systems if for a period of time they're unavailable.
A few months back, we actually had an internet outage at our clinic, and the look of panic on the providers' faces when they didn't know what to do. You know, they said, well, they were here for an annual, and I don't have any of their data. I said, well, go take a history. Go write it on a piece of paper, take the history, and work with what you have, right? Patients know if they have blood drawn. If they say they had it drawn recently, then we won't do that. But otherwise, just act as if nothing happened and just make it work.
Can I just make one more comment about that? Because this always fascinates me, right? How many of us that are out on the floor have noticed there might be like an older fax machine or maybe an old POTS line around, and so you unplug it, you put it in a drawer because it's in the way? But if you are in a situation where there's downtime, that's your backup form of communication. We don't think about that anymore because it's not how we typically work. So I feel like this is on the minds of a lot of leadership teams these days and trying to figure out what an updated business continuity plan looks like and what that means for all of our care teams. Because a lot of times we've moved away from testing things for backup purposes like, ongoing faxes if we have to get out pharmacy orders, phone calls to stay in touch with each other. We're so used to texting, right? If those systems aren't working for us, what are we going to do?
And downtime might not even be related to a technology issue. I mean, cyber attacks are happening more often in a hospital setting. That's the first thing they do is they go right to paper, right?
Yep.
Great questions.
There are so many more. But I'll share with you the questions offline, and we can kind of work to address them. Some folks have answered these questions in this setting, so that's great. If you have links or feedback, feel free to add it. But I wanted to share the poll results. Are data enabling initiatives observed in your organization mission, vision, and values? And predominantly, yes, it is. But I wanted to thank you all for coming today, and thank you for your time, Sarah, Dr. Baker, and Tina. Thanks all.
Thank you.
Thank you.